Hello, everyone. We'll get started shortly. Hello. Welcome to today's webinar, What Happens After Ovarian Cancer Treatment. I'm Maggie Nicholas-Alexander, the Senior Director of Gynecologic Cancer, Patient Support, and Education. Before today's presentation begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecologic cancer and provides outreach to the general public about signs and symptoms. Because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our support lines, please visit our website at sharecancersupport.org. Now we have a few housekeeping reminders for you. All participants will be muted during the presentation. Once Dr. Lees finishes presenting, we'll begin the Q&A discussion. Please submit any questions through the Q&A section at the bottom of your screen. Remember that the speaker cannot give specific medical advice, so please keep your questions general. Many questions were already submitted during registration, so thank you to everyone who submitted questions. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting the subtitle option. Lastly, this webinar is being recorded. In a few weeks, we'll share the recording with all registrants, and it will also be added to our website. Now, I'd like to hand it over to Dr. Lees to introduce herself. Dr. Lees, we're so excited to have you here today. The screen is yours.
Thank you, Maggie, and the SHARE team for having me. I'm really excited to be here. So my name's Brittany Lees. I'm a GYN oncologist in Charlotte, North Carolina at Atrium Health. And I was asked to speak with you all today about life after ovarian cancer treatment. And initially, I think that the question came about because of some questions about maintenance therapy, but this will expand into the maintenance treatments, but also what life looks like after cancer treatments. And I don't have a lot of slides on that, but certainly I think there's a lot of questions and I'm happy to answer that. And really, it's an honor to be here today. And I hope I can answer some of your questions. So without further ado, I guess I will start the presentation. Okay. And I think you can see now. So again, the topic of conversation today is what next? So really that means what after that primary treatment of ovarian cancer are we doing next? There we go. So for today's outline, I did think it was important for the first few slides to go through a little bit of background. I think for some folks, this may be old news to you. You're very familiar. Maybe for other people, this is helpful. But I really felt like we needed to be on the same page before we really dive into the middle part or the bulk of what we're talking about. So first, we'll just go through what is ovarian cancer, what is the backbone of treatment, and then talk about, to do maintenance or not, and then discuss some of the specific drugs that we use, and then going into surveillance and then living life after ovarian cancer, which is the whole reason we go through all of these treatments. So what is ovarian cancer? So ovarian cancer is a cancer that started in the fallopian tube, the ovary, or the peritoneum. I describe the peritoneum as the lining or the coating of the abdominal cavity. So it's like the saran wrap of all of the organs. And really these cancers can start in any of those places, but we often refer to them as ovarian cancers. There are multiple different types of ovarian cancers. And so this picture here is really just to show you the different cell types that are within the ovary itself. And each of these cells can develop into different types of cancers. And we classify those as epithelial cancers, germ cell cancers, or sex cord stromal cancers. And really the focus of today's lecture in terms of the maintenance therapies is really going to be focused on those epithelial cancers. So these are from our textbook. Our pathologists are wonderful at looking at the tumor itself underneath the microscope and further classifying based on those cell types to what type of cancer it is. And so oftentimes in older studies, we used all epithelial cancers together. And so here you've got low-grade serous cancer, high-grade serous cancer, endometrioid, clear cell, and the mucinous here on the bottom right. And most studies used to include all of those cancer types. But as we are learning more about the histology as well as the genomic or the tumor's DNA, we're starting to change how we treat different epithelial cancers based off of those findings. And so it is important to know that those differences. Genetic testing, this is about 15 to 20% of epithelial ovarian cancers are thought to be of genetic origin. And so all patients are recommended to undergo genetic testing. This is usually a blood or saliva-based test that the person takes. And it actually is about the genes that make up you, the person. And these are mutations that can put you at increased risk of cancers, as well as can be passed down to family members. These are different than genomic testing. So genomic testing is where we actually test the tumor. So not the person, but the tumor. All cancers, in order to become a cancer, develop some type of mutation. And so we're looking to see what mutations does the tumor specifically have. And then we now know, which will come into play later as we talk about PARP inhibitors, and I think you guys might know this, that these mutations, we are trying to target them. These mutations in the tumors, these are not passed down to children. They don't put people at increased risk of developing other cancers. These are just the tumor itself. And sometimes these mutations can actually change over time and with recurrences. And so sometimes if it's been many years between the prior pathology and a new recurrence, we might want to get a new biopsy to see if any of that has changed. So as oncologists, how do we decide what treatments to use? And again, some of you may be very familiar with this already, but we look at studies, and in the gold standard is randomized controlled trials, but we also have multiple types of studies in different phases and even retrospective data that we look at. But primarily with cancer treatments, we're looking to see, does the intervention actually improve how long people are either living, which is the overall survival, or how long people are living with the cancer staying away for. And that's that progression-free survival. And they're all based off of time measurements, typically months, but that can change based on the cancer type. And so you'll see that come up later in the slide. So the backbone of ovarian cancer treatment in general is typically a combination of chemotherapy and surgery. And typically that chemotherapy originally is some type of platinum-based chemotherapy. Most often we will use carboplatin and paclitaxel, but there are some variations of that. So then a lot of times that's about approximately 6 cycles of treatment. And then after treatment, we have to make a decision, usually get CT scans, and decide whether or not we are completed with our systemic treatments and thus entering surveillance, or are we going to put people on maintenance therapy? And the use of maintenance therapy has been studied many years ago, and with agents such as Taxol was not found to be very effective and had a lot of side effects. But really in the last, I would say 10 years, we've had a lot more data come out using some newer agents that show that there is a benefit in certain patient populations to the use of maintenance therapy. And so there are a lot of nuances with who should get what and why. And so I think that's where the question for today's lecture or webinar came from. So this is a graphic that I got from the National Comprehensive Cancer Network guidelines, and these are a resource for providers. They are evidence-based, and basically it just goes through, and I really wanted to put it up here so that you can see there's a number of different ways that that treatment decision gets made. And so some of it has to do with the stage, whether or not the patient received bevacizumab during their treatment, and then looking at that genetic or genomic testing results based on their BRCA or BRCA status or homologous recombination deficiency. And then we can do all different things. And so we're going to kind of dive into that next. So When do we do observation? So patients who have early stage disease, so particularly stage 1 disease, the use of maintenance therapy has not been studied nor is recommended given the very good outcomes with the use of the primary chemotherapy alone. Stage 2 has limited data within it, and particularly those with stage 2 and a complete response, we often don't require any additional maintenance therapy either, although sometimes we will use that, and again, that's in certain patient populations. So most often this is used in stage 3 and 4 patients, and again, there's going to be variability there, maintenance therapy is used in stage 3 and 4 patients, but again, variability is present based off of a number of factors. So one of the drugs that you've probably familiar with or heard of is bevacizumab. And what is it? So technically speaking, it is an angiogenesis inhibitor or a monoclonal antibody against VEGF. And so the way I think about this is that it attacks the blood supply to the tumor. So tumors need blood supply in order to get nutrients, oxygen, all of that. And so if you decrease the blood supply to the tumor, that essentially will lead to cell death. And so that is the mechanism behind how bevacizumab works, and it works in combination with traditional chemotherapy drugs. It is given through an IV, and there are 2 different dosing regimens every 2 or 3 weeks, depending on if it's being used with certain types of chemo or as a maintenance drug. There are side effects with any medication that we use, and particularly with bevacizumab, it can cause hypertension or high blood pressure that can require medications to manage. Does put folks at a little bit of an increased risk of developing blood clots, both in the lungs and legs. It can increase risk of stroke, heart attack, nosebleeds, fatigue, and it also leads to poor wound healing because, again, it's attacking that blood supply, and blood supply is really helpful when you're trying to heal wounds. And then finally, it's rare, but I always like people to know that it can cause fistulas or gastrointestinal perforations, which are holes in the bowel. And that is definitely a life-threatening event. But again, rare complication. So why use bevacizumab? So we have 2 large randomized controlled trials that looked at using bevacizumab in combination with chemotherapy, and they have different inclusion criteria. And I have simplified this slide, and there's a lot, and so that's when I get to, best to ask your doctor specifically if you have a question. But overall, the first trial looked at stage 3 or 4, again, epithelial ovarian cancer. And they looked at chemotherapy alone versus chemotherapy with bevacizumab, followed by the bevacizumab maintenance. And what they found is that median progression-free survival, so that's how long the patient is without the cancer coming back, was roughly about 10 versus 14 months. And there's a bunch of studies that break this down further and show some differences, but did show an improvement basically in how long we can keep the cancer away for with the use of the bevacizumab. Overall survival between the 2 groups was about the same, but in a subgroup analysis, which as physicians we're always trained when we're looking at research trials and statistics, you have to be really careful about those subgroups because technically speaking, unless it was designed to study that subgroup analysis, these are just hypothesis generating, but it's hard to say that the data is significant, but did think that in patients who have stage 4 disease, there might be a survival advantage to using the bevacizumab. But again, that's a might. In a similar study, but looking at patients that were lower stages, so stage 1 or 2A, and all the way up through stage 4, again, showed that improvement in how long that we can keep the cancer away for using the bevacizumab. And again, that high-risk group, so stage 4, et cetera, seems to have a significant benefit there. So PARP inhibitors, and I should say going back, they did look in these trials, which I did not include, the bevacizumab just with treatment, without surveillance or without maintenance treatment, and that advantage was not present, which is why the maintenance portion of the Avastin or bevacizumab is important. So what about PARP inhibitors? PARP inhibitors, if I can pronounce this, are technically an abbreviation for polyadenosine diphosphate ribose polymerase inhibitors. And they are an oral chemotherapy drug that basically, when you have DNA, there are 2 strands that are together. And if if for some reason there's a break in one of those strands, it's what we call a single-stranded break. Your body and your cells have a way of repairing that single-stranded break, and it's through the use of a PARP. So when essentially if your body is unable to repair that single-stranded break, it then turns into a double-stranded break. So both sides are broken. If you can't repair both sides, and there's another enzyme that helps repair the second side, then the cell dies. So it's good in tumor cells. We want them to not be able to repair those, to have those abnormalities, and then have the cell die. So what the PARP inhibitor does is it inhibits the PARP enzyme from repairing that single-stranded break so that it stays that way. Then the cell will develop a double-stranded break. If the cell has the ability to repair that double-stranded break, the cell maybe won't die. However, if the cell's ability to repair that double-stranded DNA is impaired, meaning it can't do it, then the cell will likely die. And that's where the cell uses homologous recombination in order to repair that double-stranded break. And so that's where, when we test the tumor for homologous recombination deficiency, meaning the cell lacks the ability to repair, that is when PARPs are most helpful. And this term is called synthetic lethality, but essentially it relies on the fact that the cell can't repair that double-stranded break either. And so that's where that tumor testing, and also genetic testing for a BRCA or a BRCA mutation, which also has the inability to do this double-stranded repair, that's why that's really important in terms of which patients are going to benefit most from these drugs. These, again, are oral drugs. They're taken once or twice daily, depending on the formulation, and there are multiple types. Olaparib and niraparib are currently the ones that are most frequently used. So going back to that mutational status of the tumor and why that's important here, basically, homologous recombination deficiency, or a BRCA mutation, is present in about 50% of patients with these epithelial ovarian cancers. And so 14% roughly is due to a germline, meaning a genetic mutation of BRCA1 or 2. About 6% more comes from a tumor mutation in BRCA1 or 2. And then 30% of these mutations are these homologous recombination deficient tumors, but are BRCA1 and 2 normal. And then that means 50% don't have a mutation in either, in any of these pathways, meaning that they're able to repair that double-stranded break. So what are the side effects of PARP inhibitors? There are some variations between the drugs, but overall, from a day-to-day symptom standpoint, these can cause nausea or vomiting. They can cause diarrhea, abdominal pain, fatigue. They can cause change in taste, as well as headaches. They can cause elevated blood pressures, and then lab abnormalities. So they are a traditional chemotherapy side effect. So they can cause myelosuppression, which is basically decreased white cell counts, hemoglobin, or platelets. They can cause an abnormal, it's really so a decrease in kidney function, abnormal liver function tests, as well as elevated cholesterol, and they do have a low chance but can cause myelodysplastic syndrome or treatment-related leukemia. So what is olaparib, and what's the data there? So olaparib was looked at in a randomized trial, again, stage 3 or 4. And again, this is epithelial cancers, but specifically high-grade serous and endometrioid were the ones that were included. And they looked here at patients that either had a germline, or so either a genetic or genomic mutation, specifically BRCA mutated, and they had to have had a clinical, and this is a partial response or complete response based following their platinum-based chemotherapy. And basically, after they completed their platinum chemotherapy, they then got randomized to the olaparib or a placebo drug for up to 2 years. And what they found, they didn't look at this in months, but what they found was that at 3 years, so they'd been off the drug for a year, they were on the drug up to 2 years and then off the drug for another year already, that progression-free survival, meaning that and this is looking at the percentage of patients that had disease recurrence in that time period. And basically, if they were on olaparib, 60% of patients had not yet had a recurrence, compared to 27% who still had not had a recurrence in the placebo group, indicating a significant benefit to the patients who were on olaparib. This was one of the original trials, and so we do have overall survival data. This was at 7 years, and I'll show you a graph next. But basically, median overall survival means in each group, 50% of patients, how many were still alive at that median time period. And the median overall survival was 75 months for the placebo group, but it was not reached, meaning over 50% of patients were still alive at 7 years, and so we don't have that data. So this is another way of looking at this. So this is what's called a Kaplan-Meier curve. And basically on the left-hand side, so on this y-axis over here, this is the percentage of patients that are still alive, so the overall survival. And the x-axis down here, this is looking at the months since they were randomized and started on treatment. And you can see it goes all the way over in this 84 months, that would be that 7 years. And you can see that, 67% of patients were still alive in the olaparib group compared to 47% in the placebo group. And so, one of my colleagues used to say in these Kaplan-Meier curves, the difference between these two groups, if it's a large difference, meaning there's a big spread there, that usually indicates a significance. So this definitely shows approval for patients who have a BRCA mutation, the use of olaparib. So niraparib, similar, also a PARP inhibitor. It was studied in all comers. So the olaparib was mainly studied just in BRCA mutations, but in niraparib, it was actually looked at all comers with stage 3 or 4 high-grade serous or endometrioid. And this was the niraparib versus placebo, so very similar, but up to 3 years. And what they found in the group overall, that again, there was an improvement, so 14 months versus 8 months. But the benefit was most pronounced in those who have that homologous recombination deficiency within their tumor. And so that was 22 versus 10 months. And you can see in that when they have homologous recombination maintained, meaning they're able to do those double-stranded breaks, the benefit isn't there. So that it's present, but it's not as significant. And then we don't have the overall survival data back yet. So what about using them in combination? So what about the use of both maintenance therapies, so the bevacizumab with a PARP inhibitor? And this was looked at in stage 3 and 4 high-grade serous or endometrioid. So again, same population. And basically, they got olaparib and bevacizumab, or placebo and bevacizumab. So one caveat to this is that olaparib alone was not included, which is one of the data points we just don't know, is whether or not olaparib and bev is better than olaparib alone in this group. We just don't have that data. But it did look like olaparib with bev, as opposed to bev alone, was an improvement. So again, that PFS benefit was there. And really, for the patients who had a BRCA mutation, significant improvement there by 15 months. And so we oftentimes, this is considered or recommended in certain patients, particularly patients who have a BRCA mutation. So the other medication that is used in the maintenance therapy world is an aromatase inhibitor. And this, unlike the ones we just talked about that were high-grade serous and endometrioid or clear cell for the bevacizumab, these are typically most helpful in tumors that have a high level of hormone receptors. And so the reason that is because of their mechanism of action. So basically, they are trying to block the peripheral, meaning in your adipose tissue, so outside of your ovaries, conversion of androgens into estrogen. So even when you go through menopause and your ovaries aren't producing as much estrogen, your body is still making estrogen. And so the goal of these therapies is to decrease the total amount of estrogen that you have. Very, very commonly used in breast cancer treatments because of their hormone receptor positivity, and that's where a lot of the data is from. And some examples are letrozole or anastrozole or exemestane. And so whenever I counsel patients about these, I say that basically they induce strong menopause. So hot flashes, vaginal dryness, decreased libido. They can cause some vision changes, some nausea, as well as some joint pain or lower extremity swelling. And they can cause a decrease in the bone mineral density or weaker bones. And so oftentimes if people are on these for prolonged periods of times, we'll do DEXA scans to evaluate for that osteopenia or osteoporosis or weak bones. They can cause elevated cholesterol as well as some neuropathy. So again, these are most helpful in cancers that have higher levels of hormone receptors. And we, particularly when it comes to ovarian cancer, use these in low-grade serous as well as some low-grade endometrioid subtypes. There is limited data. One of the largest studies that we have was a retrospective data from MD Anderson, from Dr. Gershenson, where he was putting patients on the letrozole maintenance or an aromatase inhibitor following primary treatment, and did show in that long-term data set and that the median progression-free survival when on an aromatase inhibitor was 65 months compared to 26 months. We do currently have an ongoing clinical trial that uses the letrozole maintenance and is looking to see actually if we might be able to change that dynamic of using chemotherapy up front and actually just using letrozole. And so we're really excited to see those results, because I think from a toxicity standpoint for patients, that's going to be a lot better tolerated. So my conclusions from this middle portion just about the maintenance therapy is just to remember that ovarian cancers have a lot of variability. They can vary by stage, histology, as well as mutations both within the person themselves as well as the tumor. Maintenance therapies have varying improvements in that progression-free or overall survival based on those differences. And so that's where providers and patients can talk through, does it make sense to use this one, that one, based on, what those statistics have shown or maybe data we don't have yet. And I always remember patients, everyone is an individual. Everyone is different. They have different medical histories, different risk factors. And so one drug might be good for someone, but isn't good for someone else because of those. And that's, what's important to talk about with your provider. There are side effects with any therapy that we do, as well as financial implications, and all of that needs to be considered as we decide on treatments. And so finally, just ask your doctor if any questions about why or why not they are prescribing a medication. We do try, I think, to explain it as best we think, but we fall short of that. And don't be afraid to ask questions. We certainly want to share why we're making those decisions for you. So regardless whether you're on maintenance therapy or, done maintenance therapy or started with surveillance, surveillance is where you still are following up. You're just not on regular, cancer-directed treatments at that time. The current recommendations or guidelines are roughly that you have a visit every 3 months for the first 2 years following treatment. Then it spaces to every 6 months and then annually. And the reason being is that the recurrences are more likely to happen early on. And that's why we see folks more often in that time period and then space it out with time. At those visits, it's very important that a history and physical exam is performed. That's where we'll find the majority of recurrences is based off of symptoms or something on exam. Blood tests can be used if you had an elevated tumor marker at the time of diagnosis, and that's a good marker. We will continue to check that. Routine surveillance imaging is not typically recommended. However, if there's elevations in those tumor markers or new symptoms or findings, we'll typically order scans, most often a CT scan, but again, there can be some variations. Some symptoms to think about. So, I typically, this is how I counsel my patients is if you're having persistent abdominal pain, we all get a cramp here or an ache there or a sharp pain here from various things that we may never know exactly what they're from, but something that's not going away that you can't really explain, I'd want to know about that. Abdominal distension could be a sign that, ascites or that fluid in the belly is back. Any changes in the bowel, so new constipation or diarrhea, again, that you can't explain because of food poisoning or something you ate, right? Those are important. Sometimes these cancers can go to the lungs. Oftentimes that is without symptoms, but sometimes can have a cough or new shortness of breath. And then, they can come back in the vaginal area, and that can be vaginal bleeding or spotting. So any of these symptoms or anything else that you have that you're just not sure of, always call your doctor, ask to be seen, and we're always happy to investigate that and make sure we're not missing anything. So, life after treatment, this is what we call survivorship. This is a time where there can be, some symptoms, no symptoms, but lots of variability between patients. I have included here, and we'll kind of walk through a few things that I've seen more commonly with patients after treatment. So one of them is I always say, chemotherapy is wonderful. It is able to kill these cancer cells and get them to go away for long periods of time, but it comes with side effects. And while some of those side effects are short-lived during treatment, some of them last for a while. And in one of those, particularly with the paclitaxel, is that neuropathy or that numbness or tingling in the hands or feet. That can go away within, I would say, give it a full year after treatment stops for it to get better. But oftentimes that's lifelong, that neuropathy stays there. There are a number of interventions that we can try, including medications and alternative therapies. I've got a lot of patients who've provided me with feedback on things that they found that worked or found from other survivorship meetings and support groups that people have found helpful. And so I'll often use some of those recommendations, including things like CBD oils or a frankincense-based cream. There aren't a lot of studies. We wish we had more that we can offer here, but certainly that is something that a lot of patients are dealing with. Similarly, hair loss or alopecia, again, oftentimes with the paclitaxel treatment, that's going to come back starting about 3 months after therapy. The maintenance therapies that are currently being used do not typically cause this, so it doesn't prevent the hair from coming back. But sometimes we do change the paclitaxel to something called docetaxel or Taxotere, and rarely, but it can happen, that can cause complete hair loss, and it doesn't regrow. And so patients are dealing with that, and unfortunately, we don't currently have a lot of good interventions to reverse that process. These last two are the ones I think a lot of people struggle with. So that's, fatigue or decreased energy levels, and then weight fluctuations, particularly weight gain. These are long treatments that everyone are going through, both in time as well as, big surgeries. Deconditioning is very, very common. And then I think there is certainly something that we haven't studied well or know exactly why, but I think there are long-term residual fatigue and weight changes that happen for patients on chemotherapy. There's lots of lifestyle interventions that we recommend. These aren't easy fixes, but certainly, dietary modifications. Here at our institute, we do have the wonderful cancer-specific dietitians that patients can talk to. And then there are great programs out there, such as Live Strong with the YMCA, for getting patients who've had a history of cancer active and in a setting that I think feels a little bit more comfortable. But all of these things, your provider is happy to talk through. We don't always have the answer or the solution, but we're certainly happy to help triage and figure out how to make your quality of life improved after these treatments. In terms of social and emotional well-being, I think that everyone processes their cancer diagnosis and their treatments differently. I certainly have had patients who come to me months after treatments have finished and say, I think I should be happy, but I'm angry now, or now I'm sad. I didn't have time to think about this when I was going through treatment because I just focused on my appointments. And, other people are able to process all of that during treatment and don't have that same experience afterwards. But I say this because it's highly variable how you feel, and it's all normal. And it's important to access resources, whether that be support groups, the share resources that they have, individual counseling, but there are lots of resources, and important to focus on, your social and emotional well-being when treatment's finish. Some patients will have had a genetic mutation that was identified that not only is thought to cause their ovarian cancer, but they may be at risk of other cancers like breast cancer. And so in that survivorship time period, it's important that we get you connected with the appropriate providers and screening that you need, as well as seeing your primary care physicians, dental cleanings. All of that is really important to get back to after we finish treatments. And then finally, this one's near and dear to my heart, but sexual health. And, this is a hard one that people don't always like to talk about. And there's studies on studies that show that doctors don't talk about it. Patients want to talk about it, but don't talk about it because they don't think their doctors want to. We're trying to break down that barrier, but certainly, there are side effects from the therapies that we use, including, those aromatase inhibitors or surgical menopause directly affect sexual function. But all of the treatments that we do potentially have an impact on that. And we are always happy to discuss this and what options may be available for treatment or any counseling. We've got pelvic floor physical therapy. There's lots of different things here, and I'm certainly happy to answer any questions about that. I can give a whole lecture on that. And so I figured I would just open it up to questions if anyone has any. So that's all I have for my prepared slides today, but I am genuinely excited for questions.
Thank you so much, Dr. Lees. You covered an incredible amount of ground in 30 minutes, so that was great. And now we can start the Q&A. You can still submit questions in the Q&A section at the bottom of your screen. We will try to get through as many questions as possible in the remaining time. So one question that comes up a lot is just how to not be paranoid about every ache and pain and that it could be a recurrence. Do you have any suggestions on how to manage the anxiety around fear of recurrence?
Yeah, I don't have any perfect advice because I haven't had to personally go through that, but I know when you've gone through cancer treatments, it is very scary to think about it coming back. And unfortunately, with ovarian cancers, we know that they have a high propensity of coming back. And I think that the best way to manage that fear, I found for a lot of patients, is talking with other survivors and other patients to understand what they've gone through. I really think that it is, so many of my patients will come in and for their visits, and they're usually anxious and nervous. And they're like, I was fine until yesterday. And then we had our survivorship visit, and now I'm really nervous. Like, could it be back? And I always say, if you're feeling fine, the likelihood that it's back is low, but certainly possible. But that's the reason I'm seeing you, and we're keeping a close eye on things. In terms of all those aches and pains, that's why I really try to stress there are things that aren't going away. So we all, with or without cancer, get aches and pains in different places, and that doesn't change after treatment. If anything, it's probably worse after treatments, that you're going to have more symptoms from the treatments that we did. But really trying to think through about, like, yes, I probably have a stomach ache because I just ate spicy tacos. Like, that's more likely what's causing it than your cancer. But I think that anxiety is very real and very normal for people to have. And I think actually owning the fact that that's normal and that's what's happening, and trying to work through that, and convince yourself that, what could this be? What else? And then if you don't know and you're really worried about it, give your doctor a call, and we're happy to talk through, why that symptom has us worried or not worried, right? And so sometimes that can be helpful, or again, support groups. And I think if you're finding that anxiety is overwhelming, where you can't do your day-to-day life because you're having so much anxiety around those symptoms, that's when it's time to make sure that you're getting professional help from a counselor, and maybe even medications to help manage that. But some degree of anxiety is very, very normal.
Great, thank you. And then we're getting a question asking what you think about tests like Signatera to help identify early signs of recurrence.
Yeah, so we are still waiting for a lot of data in relation to Signatera, or circulating tumor DNA tests. The whole design behind any of these tests, including like the CA-125 or the CEA, which other people may be familiar with as well, is to try to find cancers early to be able to treat them. when it comes to ovarian cancer in particular, we actually have really good data that looked at treating based on the CA125 alone versus CT scan evidence of tumor recurrence. So basically, patients were randomized, following their CA125s regular. And if the CA125 started to elevate, of course, CT scans were ordered. If there was no evidence of disease on scans, some patients were randomized to getting started on chemotherapy just for the CA125 alone, which in my mind is similar to Signatera being positive alone. And then others waited. So CA125 could stay elevated for a few months, but waited until we had CT evidence that, oh, there's the tumor, it's back, and then starting treatment. And in that randomized trial, and again, this was with an epithelial ovarian cancer, high-grade serous, what they found was the patients that got treated earlier with chemotherapy just for that, what we call biochemical recurrence, they didn't live any longer. They just were on chemotherapy for longer. And so I think that that's one of the things when I am trying to figure out the helpfulness of Signatera is, if it's going to tell me that it's back, but I don't have CT evidence, I think that's probably similar in this instance to having a CA125 that's elevated, but no CT evidence. And what we found is that we aren't changing how long people are living. We're just giving them more chemo, and that's more side effects. And so I think that they can be a helpful test if you don't have an alternative test that was positive. So if your CA125 was not elevated or your CA was not elevated, we don't have another way of monitoring that. I do think that Signatera is a good use in those patients. Mm-hmm. But similarly, I don't know that I would treat based off a positive result there alone, but that would prompt me to get a CT scan, and if positive, go ahead and treat.
Great. And so you mentioned a lot about CA125, and we are getting some questions about that in terms of the efficacy and if it's a viable indicator of a recurrence. So maybe you could speak a little bit more on that as well.
Yeah. So CA125 can be elevated for other reasons outside of cancer recurrence or cancer diagnosis. And so, inflammation in the belly cavity can produce that, particularly ascites unrelated to tumor, but also with tumor. But there's a number of different things that can elevate that number. And so it's not perfect. And we caution patients that just because it's elevated, again, doesn't mean that the cancer is back. And so it is just one variable that we use to identify if the cancer is coming back. And again, that's what we talked about, is that, if the CA125 is going up, but I don't have CT scan evidence that the cancer is back, we usually continue to trend until we see evidence that the disease is back. Some patients, it's for various reasons, it's never elevated. We know in early stage ovarian cancers, about 50% of them will not have an elevated CA125 at the time of diagnosis. So again, it is not a perfect test, but I think it is a very useful number. If you had elevations when you were diagnosed, it's one additional way we can monitor for recurrence, for potential recurrence in the survivorship time period.
Mm-hmm. Great. Thank you. And then, so we're also getting some questions about scans and whether those imaging tests are do most gyn-oncs use those during follow-up or not? And what do you recommend? When do you think it's appropriate to do scans?
Yeah, so we have some general guidelines that we look at in terms of, with different cancer types, when to use what scans and how frequently. And really with ovarian cancers, it's not currently recommended to do routine CT surveillance, meaning that, every 3 months you get a scan or every 6 months. It really is recommended to get those scans if there's any new symptoms, findings on physical exam, or if that tumor marker was a good marker for the patient and that's starting to change or go up, then that would be an indication to consider a CT scan. Typically, we use CT scans with ovarian cancer, although there are some patients where a PET might be preferable, but in general, CT scan is what is in the guidelines.
Mm-hmm. Great, thank you. And then this person is asking whether they understood correctly that no BRCA mutation and high-grade serous means that there's really no maintenance therapy. That would make sense?
That is not true. So let me clarify. So basically, the maintenance options would be the bevacizumab, and that one can be used in all epithelials really, but typically clear cell, endometrioid, or high grade serous will use the bevacizumab. And that the difference is that with a PARP inhibitor having a BRCA mutation or the tumor having a homologous recombination deficiency, those patients seem to benefit the most from a PARP inhibitor. Patients who don't have those mutations still benefit. So there are some benefits. It's just a much smaller benefit. And so that's usually a conversation with the provider and the patient about what options to consider. Was that more clear? I'm happy to try to explain it differently too.
We'll see if there's a follow-up about
Okay.
that, if that wasn't clear. Thank you. And so we're getting a question about, so did this person understand correctly that weight gain can be a long-term side effect? Is weight gain more common than loss?
So I would say, anecdotally in my clinic, yes, I think that a lot of patients struggle with weight after chemotherapy. Certainly during chemotherapy, it can be a combination depending on how on people's appetite, because some people really have poor appetite when they're first diagnosed and going through treatment, and that can lead to weight loss. However, we give a bunch of steroids with treatment on infusion days as well as after to help with the nausea, which I think is extremely important. But steroids can lead to fluid retention and thus weight gain. And then, I think for women, after they go through menopause in general, weight loss is a lot harder. On average, in studies, women put on, I forgetting the exact number, so don't quote me on this, but I think it's about 1 pound a year. And so it's hard to lose that weight. And so I think that's one of the biggest things I see is that there's continued weight gain. And I think it's a combination of chemotherapy and something that it's doing, as well as just aging process. And I'm hopeful that we'll get some more data on that.
Okay, great. Thank you. And then we're also getting a question about whether vaginal dryness could be worse after chemo than that would occur just from menopause alone.
So I don't know that it's worse from chemo. There's nothing specific about chemotherapy that would make vaginal dryness worse. I think it's typically from menopause. And so I would say that some people might notice those symptoms more, but I don't know that it's actually from the chemotherapy.
Okay, great. And okay, a lot of questions about PARP inhibitors. So one question that comes up a lot is for maintenance therapy, how long should someone be on a PARP inhibitor?
Yeah, so I would say that different people follow slightly different rules on this. I think that, if you stick to the studies specifically, right, the studies themselves, the olaparib was for 2 years, niraparib was for 3 years. A lot of people out there think that 2 years overall is sufficient. A lot of times that's what we will do here is 2 years for either one. But really the data from the olaparib in particular, because that's the longest term data that we have, shows that even after the PARP inhibitors are stopped, there's still a durable benefit, meaning it's not that you stop the drug and then now we start seeing cancer come back immediately. It lasts for many years after that. And really it's a balance of side effects from therapy versus the anticipated benefit from a cancer standpoint. So I think it's variable. And so it's hard for me. I'm not trying to beat around it, but I do think it depends on how you interpret the data and make that decision.
So, and given that, so what is the data for taking it more than 2 years? And would that mean that certain risks, like for the secondary cancers, would those potentially increase with longer usage?
I don't believe, as far as I know, that we have the data that would tell us definitively that answer, but that is one of our thoughts, is that more treatment could increase that risk. And so I do not know of data aside from, as I said, in the niraparib PRIMA trial, they did use the niraparib for 3 years. There's no other data in terms of randomized trials that had people on that drug for longer than that.
Great, thank you. And so, what would you say, like, at what point post-treatment is it less likely that an ovarian cancer will recur?
So really, they can recur at any time point. So we know the highest risk is usually within the first 2 years after primary treatment. But that being said, they can still come back in those years following, and thus that's why we still recommend that close surveillance in that time period.
And then back to PARP inhibitors, we're getting some questions about if there's any information on the efficacy at lower dosages.
So with niraparib in particular, they did look at differing dosages based on patient weight, as well as platelet counts that started out. And basically with the differences in the higher dose versus the lower dose, they did not see any differences in terms of outcomes from a cancer benefit standpoint.
Great. And then were you, okay. This person is asking if the chance of recurrence is lessened when the ovaries are removed.
So certainly when we have, I guess is the question about like removing like after surgery for a primary surgery?
It just says, is the chance of recurrence lessened with the ovaries removed?
So in general, with ovarian cancers, we will remove both ovaries at the time of surgery. There are instances where we'll do what's called fertility sparing surgery, and those are usually in very early stage cancers. And so we will leave the ovary behind in order to allow patients who are interested in getting pregnant after their cancer diagnosis and treatment. We will leave that other ovary in place. And in those very early cancers, with very limited data, we don't think that increases the risk of recurrences, which is why we allow that other ovary to be retained. Any higher stage cancers or patients who do not wish to have children and thus need that other ovary, we would always recommend that both ovaries come out.
Mm-hmm. Great, thank you. This person is asking about, so they have some GI problems that they didn't have that they got through going through treatment. But over a year after finishing treatment, they still are having some problems with their gut. Is there a chance that could continue on or get better?
Yeah, I would say that if it's still ongoing 1 year out from treatment, it's probably going to continue. Most of, we think about things as acute versus chronic. So acute side effects tend to improve within the first 3 months or so after therapy has ended. That doesn't mean they'll never get better. And then the more chronic, if it's ongoing longer than that, I feel like it's unlikely to resolve just because it clearly was something that changed in the body or in the gut that's now having this issue. The GI tract is a very responsive organ to stress, to chemotherapies, and a number of different factors, as we all know from dietary changes that you can make there. And so it can be tricky to get that regulated. I think seeing a GI doctor if you're still having issues, if you haven't already, so a gastroenterologist would be really helpful, as they may have some additional treatment options to try to help.
Great. And then I'm wondering if you could touch a little bit on some of the treatment options that may be available if someone does experience a recurrence.
Yeah, so if a recurrence is identified, most often we are going to treat that with additional systemic treatment. So that's typically in the form of IV chemotherapies. And which treatment we use depends on how long since the last treatment did the cancer come back. And that just is based off of response rate. So if we gave a platinum, typically we refer to these as platinum resistant, platinum refractory, or platinum sensitive. And so basically, if you had your primary treatment with the carboplatin and the cancer stayed away for many months to years, we think that cancer clearly responded really well to that drug. And so we'll often use that again. If the cancer comes back very quickly after stopping that drug, well, clearly that one wasn't very effective. And so we're not going to try that one again. We're going to change it to something different. But almost always it's systemic treatment. There are some rare instances we'll use surgery, but those are fairly rare. And most often it's systemic treatments. We've got lots of different chemo drugs that we use with different combinations. There's new drugs that have come out just in the last 5 years that have found to be effective. And then tons of clinical trials out there that are, again, as I talked about, looking at those genomic or tumor differences between them and trying to target those.
Great. And then we're getting just if you could briefly reiterate the difference between what germline and somatic.
Yeah,
means.
it's very confusing. But basically, you yourself and all of your cells that were passed down to you from your parents, you have DNA, and in that DNA, you can have a mutation. And that's genetics. So that's something that all of your cells will have that mutation in them, or most of them. And thus puts you, if you have a mutation there that's a cancer risk mutation, like a BRCA mutation, that puts you at increased risk of developing a cancer. Then that cancer, so if you had a BRCA mutation, that ovarian cancer that you developed, if we were to look at the tumor itself, it's going to have that BRCA mutation as well. It might have other mutations in addition to that BRCA mutation, because cancers often have more than one, but it got that BRCA mutation because it was in your genes. Genomic testing is the tumor itself. So that tumor, we can test it, and it might have a BRCA mutation. It doesn't mean you, the person, have a BRCA mutation. Your tumor, for whatever reason, those cells developed that mutation, and that's what's driving it to be a cancer, but you don't carry a BRCA mutation, and that's genomic testing. So that's the difference there. And we look at both because actually whether you've got a genetic mutation with a BRCA or just the tumor has the BRCA mutation, or that homologous recombination deficiency, and I wish there was a more simplified way to say that, but they'll respond to those PARP inhibitors. And so it's important that we know both. And also knowing your genetic mutation is important for your counseling for potential additional cancer risks, but also whether or not your family needs to get tested.
Great. Thank you for clarifying.
Yeah.
I know it gets confusing. And so we're getting a question about the HE4 tumor marker, and is that used often in ovarian cancer screening?
So again, it all depends on what was elevated at the time of your diagnosis. So I think there are some places that are using HE4 more frequently with CA125 to determine the risk that a cyst on the ovary might be cancer. And certainly if that was markedly elevated, it could be a really helpful marker to continue to follow in the surveillance. I don't tend to add it if it wasn't already elevated or known ahead of time, particularly if the CA125 was elevated. Doing additional testing probably, is just more expensive without a lot of benefit. Because again, that CA125 was a good marker and we see that go up, that's when we'll get those CT scans. And as we've shown in that randomized trial, treating based off of visible disease rather than a number on a blood test really has the most benefit from an overall patient standpoint. HE4 can also be elevated with chronic kidney disease. And so in folks that have chronic kidney disease, that may not be a good marker.
Great, thank you. And so I'm looking at the time, and I think it's a good, we tried to get through as many questions as possible, but maybe you could just sort of distill what are your main takeaways for patients from everything you presented and all of the questions we've gone through? Like what message would you want to leave everyone with?
Yeah, so I really think that it's very exciting that we have finally started to find new therapies and different therapies for patients with ovarian cancer, and I think we're really getting better at understanding what's driving specific cancers and trying to figure out how we can treat with a more individualized approach. However, in doing so, with all of these findings, it gets pretty complicated for providers as well as for patients when patients are talking to other patients, right? Why did you get this versus why did I get that? And I thought we had similar, I think there's a lot of nuances within those treatments. And so I'm hopeful that I helped explain some of why that might be. But certainly if you ever have any questions about, your care specifically and why not, I have patients all the time that come in and ask me some of these very specific questions like, hey, why didn't we get Signatera? Why are we doing it this way? Why are you doing this? What did that test show? Why are we getting the genetic testing again? You already told me that the tumor testing was back. And so we go through all that and really and truly, I think all of us, even if we haven't brought that information to you, want you to have that information, and we want you to understand why you're doing what you're doing. And same thing in their survivorship time frame. There's a lot of reasons that we do or do not get scans or blood tests, and there is data behind that, and it's all different for all different cancer types. So I get that from my family all the time of like, well, they had this cancer and they got a PET scan, why don't you use PET scans? Or and it's all based off of what we've seen in terms of being effective, what the side effects of those are, financial implications, that all plays into it. But really, it's about, we want to find your cancer when we can treat it and when it is going to be most effective to treat it with fewer side effects for you, right? So quality and quantity of life are really important to us.
Great, thank you. And since there were a lot of questions, we tried to get through a lot of the PARP inhibitor questions, but I know that's a topic that there are just a lot of questions about. So I want to make a plug for the fact that on our website we have a webinar from last year where it's just all about PARP inhibitors. So check that out if you still have questions. And then also I saw a question about hernias. We did have a webinar on hernias in the fall, so also check out that if you have any specific questions about hernias and hernia repairs. But thank you so much, Dr. Lees, for your thoughtful and thorough answers to so many questions. And thank you to everyone for submitting all of these great questions and joining us here today. We'll have the recording of this program available on our website in a few weeks. Please also check SHARE's website for upcoming educational programs and support groups. Here are some of the upcoming ones. And also don't forget to follow us on social media as well. Please take a moment to complete the survey at the end of the webinar. The survey will pop up in the browser when the webinar ends, and the link will also be in the follow-up email. All surveys are anonymous, and we really use that feedback to improve our programming. This concludes today's webinar. Thank you again, Dr. Lees, and I hope everyone has a great day.
Thank you for having me.